Wonderful. Write your questions down. You're going to have a chance to ask. I'm sure there'll be plenty. So back for return engagement, Dr. Gore is going to be talking about side effects of treatment.
I apologize for my prevalence on the roster today. So quality of life. Quality of life is something we get a number of questions about. And a lot of what I'm going to present is stuff that is not new to a lot of you. And a lot of you have had some profound input that has influenced the direction of some of what we're doing here locally. And this is going to show you how we're taking some of that local work and broadening it really to a national and international effort. So why are these patient-reported outcomes, why are they important? Well, they're important because what we think, what we perceive as the physician is just simply wrong. What you see here is you see in green what the patient says is a problem, and in blue what the doctor says is their patient's problem. And you can see that it's exactly. Doctors woefully underestimate their patients' problems with incontinence, woefully underestimate their patients' problems with urinary frequency and sexual dysfunction. So this concept of patient-reported outcomes is really critical. It's not enough for me to just say, well, this is how I think you're doing based on what you told me in that 5-minute clinic visit. It's really important to understand how you're doing, in your own voice. And so we measure patient-reported outcomes using both function, so this sort of objective measure of how you're doing, as well as bother, which is your perception of the distress you feel as a result of your urination, your sexual function, your bowel function, things like that. And we try to measure how you're doing in general, your overall health, as well as some more maybe prostate cancer specific domains like urinary function, sexual function, and bowel function. And we have a number of surveys that we use to do it. There was a recent international consortium of health outcomes experts that selected one of these tools, but in general there are a number of ways that we can measure how you're doing from a quality of life standpoint. And there are a number of registries that in the 90s started saying, well, gosh, we need to clarify from the patient's perspective how people do after prostate cancer treatment. And a couple of these are listed here. There's Capture, which combines community data with academic centers, with VA centers. There's the prostate cancer outcome study that Dr. Stanford was heavily and continues to be heavily involved in, that took a population-based sample of men with prostate cancer and tracked them from the mid-90s and recently published, and I'll show you this, their 15-year outcomes. There's an update to this called CSER, which took a new sample of men with prostate cancer just a couple of years ago and is looking at maybe the quality of life impact of some of these newer treatments for prostate cancer. And then there's also a multi-center effort that only focused on academic centers. And so what have we learned from these? What have we learned from these large clinical registries that looked at patient-reported outcomes about how they're doing with respect to their prostate cancer treatment? Well, if we look at the blue line here, that's surgery. So we know that urinary control, or your ability to hold your urine, appears to be worse after surgery than it is after radiation treatment. And this is just to show you that a higher score on this curve is better. That sexual function appears to be similarly affected by all of the treatments. So anyone that tells you that your sexual function will not be impacted by prostate cancer treatment is not correct. Bowel function typically is not robustly disturbed by prostate cancer treatment. And the prostate cancer outcome study echoed a lot of these findings. So those results were up through 10 years. These results are up through 15 years. And you can see that just like Capture, continence is better after radiation than it is after surgery. Sexual function, so better is higher. Sexual function is impacted irrespective of the treatment that you have. And bowel function outcomes appear to be better than urinary and sexual function outcomes after prostate cancer treatment. We did our own work, and what we did was we tried to look at the probability that you would return to your baseline quality of life. And that kind of echoes a question that patients ask us, which is, well, how am I going to do compared to how I was before treatment? So these curves try to echo that. How are you going to do compared with how you were before treatment? So this is your likelihood of returning to your baseline urinary control. And you can see it's pretty good after radiation. It's not quite as good after surgery. If after 2.5 years you still have unsatisfactory urinary control, it's unlikely to continue to get better. So after a couple years, you should start thinking about whether you should pursue secondary interventions for your urinary control. Sexual function, this is return to baseline. So this is your likelihood of returning to your baseline sexual function. is pretty profoundly impacted after all of the typical treatments for prostate cancer, whereas bowel function isn't. Oftentimes people return to their baseline bowel function after prostate cancer treatment. Now that's one end of the spectrum. That's sort of objectively how you're doing. This is how bothered you are by your symptoms. And this is what kind of comes across our doorstep. This is when you come to us and say, I'm really distressed about blank. And so this shows you that after surgery and radiation, that urinary bother tends to be actually higher after some of the radiation treatments than the other treatments. This is brachytherapy in red. And higher after surgery early, but by the time people are a year out and more, the level of distress people experience is similar across all three treatments: external radiation, brachytherapy, and surgery. So there was a high-level evidence review that gathered up all of this quality of life data for the previous decade and came to a couple conclusions. Number one, bowel problems tend to be uncommon, but if they are going to happen, they're more likely with radiation. Urinary control problems, urinary incontinence, are much more common after surgery to remove the prostate. And sexual function problems appear to be common after all of the different treatments for prostate cancer. Now, we translated these quality of life outcomes into this concept of decision aids. And so one way in which we can try to reduce the side effects of prostate cancer treatment is to better match you with the treatment that you're going to receive. And so what I mean by that is everyone comes into this process, this prostate cancer diagnosis, with their own values and preferences for how they want their life to be led. And that can influence which treatment is best matched for you. So the Agency for Healthcare Research and Quality, and you can find this online. It's a little bit of a long URL. But it gives you information, right? It collects your values and preferences, and then it delivers unto you some coaching for how you can communicate with your prostate cancer provider. And a number of decision aids, like the AHRQ decision aid, have looked at how these decision aids can help men newly diagnosed with prostate cancer. And in general, they help men make a better decision. So they take away some of that uncertainty and conflict that you experience when confronted with a new prostate cancer diagnosis. And they do some things like increase your satisfaction with your role in your decision, increase your ability to navigate your own uncertainty, things like that. So this concept of decision aids is important. But where decision aids somewhat suffer is in the individualization of a prostate cancer diagnosis. And this is trying to put sort of a mathematical spin on it. But the reality is giving you some stock content like, continence is better after radiation, bowel function problems are better after surgery, things like that. It ignores the fact that everyone has a very variable trajectory after prostate cancer. So this is showing 300 men who had prostate cancer surgery and had perfect continence before their operation. After their surgery, within the first 2 months after surgery, their outcomes were all over the map. So you can see 300 different lines going all over the place. If we just look at the top quartile, the people that had the best urinary control early after surgery, they tend to continue to do well through 4 years after treatment. So if a man comes and sees me 6 weeks after their prostatectomy and they already have good control, I can counsel them that they are likely to maintain it. But if they don't, if they are in this bottom quartile, their trajectory is all over the map. And so this idea of sort of stock content decision aids, while they appear to be helpful, they ignore sort of the individual trajectory that men go through as they experience prostate cancer treatment. And the reality is, this is an emerging concern that we can now address, right? We have tablets, we have smartphones, we have ways to get your information, your patient-generated data that we didn't have before. But we also have graphic software, we have better computing software so that we can take that information and do cooler things with it than we could even 10 years ago. And this is sort of the design concept that emerged from a lot of the foundational work that we did as far back as 2010, 2009 when I first got here. And this is our kind of design concept of QOL Tracker that takes these patient-centered questions that many of you contributed, like, how am I doing compared to how I was before treatment? So that tells us that it's important to look at your longitudinal trajectory. how am I doing compared to other men? How can I compare apples to apples instead of apples to oranges? So some sort of normative score. So how can I compare me to men like me? And this idea that I want to be able to generate expectations for the future. So how am I doing now, but can I expect to get better, get worse, or sort of stay the same? And part of that relies on patient matching. So some of the sort of under the hood work that we're doing is we're working with biostatisticians to try to model these individual patient trajectories. And we're learning that with some specificity, we're going to be able to match men to men like them to create your own individual expected trajectory. And that work is being synthesized and promulgated by Movember, actually. And so I will have to grow a mustache in perpetuity. I will never be able to get away from growing a mustache. But Movember is investing a lot of money. I don't look good with a mustache. Many of you look good with a mustache, but I don't. So that's particularly painful to my impressive vanity. Movember is investing a lot of money in survivorship care. And so survivorship care, that's the concept that, a new cancer diagnosis is daunting, it's scary, you either feel like you need to have some active treatment or you go on to active surveillance, but you've emerged from that initial diagnosis and treatment phase, and now you're dealing with the after effects of treatment. That's survivorship. And so we have several interventions that we're moving forward with in this Movember program. Self-management, helping men make decisions about either their newly diagnosed prostate cancer or later on in their prostate cancer trajectory when it's come back potentially, social support, sexual health recovery, and sort of overall wellness, sort of a lifestyle changes that are important to prostate cancer care. And we're leading up here at the University of Washington the self-management portal. So this integrates a lot of the work that we've done with our design concept of QOL Tracker with the possibility of broadening these efforts to a large audience at 15 research sites and a web-based platform that is going to allow us to collect patient information, distribute to you a feedback report of how you're doing contextualized with the outcomes of other men like you, and then based on how you're doing and the bother or distress that you experience as a result of how you're doing, output to you self-management content to help you with these detriments. So what's unique about prostate cancer is if you have a problem with urinary control, if you have a problem with sexual dysfunction, there are treatments for that. Now you may not be getting offered some of those treatments, but we have these secondary therapies available to help with some of these dysfunctions. Some of them may be behavioral, like Kegel exercises, but trying to target self-management strategies based on your own individual outcomes is one of the primary goals of what we're going to be doing in Movember. This is a slide that I've been showing a lot recently, and it's just trying to highlight the value of patient-generated data. So I saw a talk by a mathematician that was very impactful to me about putting your milk crate on the internet. And what he means by that is, we all in college generated a lot of intellectual content. I wrote a bunch of essays about whatever Shakespeare play I had to read, and that intellectual content gets stored in a basement collecting dust, whereas actually that content has value. Just like your individual patient-generated data has value. That value is not currently being harnessed. So there's a website called Patients Like Me that tries to collect patient-reported outcomes from patients with rarer cancers. And so these graphs show outcomes of patients with Lou Gehrig's disease, ALS. And what they found was that a lot of patients were using off-label lithium to do anything they could to stave off the really horrible progression of that disease. And they were able to take patient-generated data to do high-level comparative effectiveness research to show that this off-label use of lithium didn't actually make a difference in their ALS trajectory. So that's taking patient-generated data, not from a clinical trial, through naturally collected sort of milk crate data and doing high-level research with it that we can learn a lot from. And so I think that is maybe a tall goal, but something that we can aspire to. So importantly, treatment has side effects. Prostate cancer treatment has side effects. Anyone that tells you otherwise is not being truthful with you. There are ways to create decision support aids that help you navigate this decision-making process and make it easier for you and better match your treatment with your own personal values and preferences. But our hope is that with these new biomedical informatics interventions, we can try to create tailored just like we talk about personalized medicine using genetics, genomics, personalized medicine using your values and preferences and your own personal outcomes to improve the survivorship care for men with prostate cancer. I will put in one quick plug, that those of you in the audience have had a lot of input in the direction of this program, and that's input that we're going to continue to solicit. So if anything on these slides impacts you or drives you to want to be involved, please don't hesitate to send me an email. Thank you very much.
Thank you. So the last talk in this session before we go to the Q&A is Nola Klemfus, who's a manager of our Act Smart program, which is the IPCR 6-part plan to reduce the impact of prostate cancer and eventually lead to a cure. So this really extends on from Dr. Gore's work, and Nola's going to describe this new nascent project called Empower.
Thank you, everyone. I am so excited to give you guys a preview of our Empower project because it really